Ladies and gentlemen, thank you for standing by. Welcome to the Meaningful Member Engagement Series. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. If you have a question at that time, you can press star then 0 on your touch-tone phone. If you need operator assistance during the call, you can press star then 0. I would now like to turn the conference over to our host, Amy Herr. Please go ahead.
Thank you, and welcome everyone. My name is Amy Herr, and I work at the Bluhm Group. Thank you for joining us today for the Meaningful Member Engagement webinar series, and today's webinar on hard-to-reach populations, innovative strategies to engage isolated individuals with behavioral health needs. This webinar is the third in the series, presented in conjunction with Community Catalyst and the Bluhm Group, and supported through the Medicare and Medicaid Coordination Office, MMCO, at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance and actionable item tools based on successful innovation care models, such as this webinar series. To learn more about our current efforts and resources, please visit resourcesforintegratedcare.com for additional details. The website, resourcesforintegratedcare.com, also has complete bios for each of the speakers on today's call. Within a few days, we'll be posting a recording of this presentation, the slides, and the Q&A from the call on our website. If you have any questions or additional comments, please email us at ric@lewin.com after the call. During the call, you can use the Q&A function on the web platform. Before we get started, I'd like to remind you that microphones will be muted throughout the presentation, but there'll be a question and answer opportunity at the end of the call. At this time, I'd like to introduce our moderator. William Dean is the Delivery System and Consumer Engagement Manager at Community Catalyst. William?
Thanks, Amy. Hello, everyone, and thanks for joining us today. As Amy said, I'm with Community Catalyst, which is a national nonprofit consumer health advocacy organization working in over 40 states to bring the consumer voice to any discussion that impacts their health care, whether that be at the federal or state policy level, at the delivery system or health plan level, or the individual patient provider level. I want to thank the Bluhm Group and the Medicare-Medicaid Coordination Office for working with us to put out this series, and I invite attendees to check out our consumer engagement tools at communitycatalyst.org. I'm joined today by Julie Bluhm, the Clinical Operations Manager for Hennepin Health, an award-winning safety net accountable care partnership serving the Medicaid expansion population in Minneapolis, Minnesota, and Laurie Lockhart, the Health Resilience Program Manager at Care Oregon, the recipient of a Center for Medicare and Medicaid Innovation Grant and delivery system to Medicare, Medicaid, and dually eligible beneficiaries across 11 counties in Oregon. Next slide, please. So right now I'm just going to outline an agenda for today's discussion. After I give a brief overview of other resources that are available that will help you strategize on finding and engaging your members, Julie will present on Hennepin Health and take a deep dive into their care coordination model and other innovative strategies that they're using. Then Laurie will present on Care Oregon's approach, their health resilience program, and how they've succeeded to find and engage members and develop trusting relationships with them. After Laurie's presentation, we'll do a couple of interactive polls to learn a little bit more about you before we dive into a question and answer period. Next slide, please. So before we get started, I wanted to make sure that you all know about some really helpful resources on today's topic that are out there, since we know that this can be a really challenging issue for many of you. So first, Resources for Integrated Care has a terrific brief available on their website entitled Locating and Engaging Members, Key Considerations for Medicare and Medicaid Plans. So if you haven't already done so, please take a look at that. Next slide, please. And then the Center for Healthcare Strategies, with the help of the Commonwealth Fund, has brought together 7 particularly innovative health plans you see on your screen. Together, these plans make up the PRIDE Consortium, and they've developed 2 webinars and related briefs, so please take a look at these at chcs.org. Now I'd like to turn it over to Julie from Hennepin Health. Julie?
Good afternoon. Thank you so much for having me. So I'm here to talk about Hennepin Health, which is a healthcare demonstration project taking place within our county of Hennepin County, which is the largest county in Minnesota and encompasses Minneapolis. Next slide, please. So Hennepin Health is a partnership between 4 county-owned organizations. Our county-owned medical center, which is a safety net hospital, county-owned FQHC clinic, located in an underserved area of Minneapolis called North Point. Our Human Services Public Health Department from Hennepin County, which includes public health clinics as well as case management and eligibility. And then a county-owned managed health plan called the MHP. We operate as a Medicaid expansion MCO option, and we operate upon prospective enrollment via managed care choice, and we're also the default option in Hennepin County for individuals in Medicaid expansion. We have a capitated reimbursement from our state Medicaid agency. So we're really looking at having, or defined by having, a very defined and small provider network that is united by a shared electronic health record. So we have been able to get our human services population or employees on the shared health record with the hospital and the clinic, which has been really important, as well as the managed care organization. Our risk-sharing funding model allows us to align our resources towards avoidable utilization. Essentially, we realized at one point that our human services and hospital were really unable to work in alignment towards the same goals of reducing avoidable utilization, since so much of the hospital is dependent upon those resources. We've really based the model on integrating medical and social services and really focusing on addressing social determinants of health. And we're operating on a consensus-based governance structure between all 4 partners. Next slide, please. So we're looking at a current enrollment around 11,000 members, and we're serving the Medicaid expansion county population in Hennepin County, so 21 to 64-year-old adults without dependent children who are non-disabled at or below the federal poverty level. Our population characteristics are mainly male and racial and ethnic minorities, and we see a lot of common overlapping issues such as mental health conditions, chemical dependency, lots of homelessness and unstable housing, chronic physical conditions, and a general lack of social support, and resulting in a lot of use of the emergency department to access care. Our premise at Hennepin Health is really that we need to be able to meet these individuals' basic needs before we can meaningfully impact health, and this has really helped us to focus on this population in a way that we haven't necessarily been able to focus on before. Next slide, please. So Hennepin Health is really based on a care model with care coordination. So essentially we've chosen to do an embedded in the clinic model. So our care coordination teams are in the primary care medical homes. And we really have chosen to rely upon a strong community health worker role both inside and outside of the clinic. Hennepin County Medical Center has also pioneered what we refer to as an ambulatory ICU. So it's a completely team-based care clinic for our highest utilizing members and highest utilizing residents of Hennepin County in general, so not just those that are in Hennepin Health. We've really been working on supplementing the clinic care coordination teams with targeted behavioral health and social service interventions. We also supplement the teams with clinical coordinators who are RNs and social workers, and we've really found that to be a really nice complement of skill sets to work together as a team to meet our members' many needs. Again, all of these providers are documenting in a shared electronic health record. So essentially when Hennepin Health was formed, we thought if we build this really great clinical care coordination model within the clinics, our members will come and be excited to be in these clinics and stay. But we quickly found that wasn't the case, that a lot of the members, particularly due to unstable housing and the fact that we're the default enrollment plan, are unstably housed and live very transient lifestyles. And so we're really getting poor demographic information and having a really hard time connecting those individuals to care. Additionally, we found the need to start to prioritize and help our staff in the clinics prioritize their interventions, because very quickly we realized that by putting really great care coordination teams within the clinics, that they were highly valued by the physicians, and they quickly became quite overwhelmed. Next slide, please. So to respond to some of this being overwhelmed in the clinic and need to prioritize our care coordination, we developed what we call a prospective or predictive risk tiering model using CMS's hierarchical condition categories, or HCC risk scores. Essentially, we were able to use these HCC risk scores to create tiering based upon risk for future healthcare costs. We decided to break it into 4 different tiers. We have an extreme, a high, a rising risk, and a general priority category. And essentially, we have chosen to target and prioritize the 2 highest tiers with the care coordination staff that are located in the clinics. One criticism of this model that we are continuing to work on or hone is because our model is really based on this idea of social determinants of health being such an integral part of what we're doing. We are continuing to work on the development of an unstable housing indicator that will be incorporated into this hierarchical risk score and tiering, so we can really ensure that we're prioritizing people with unstable housing as well. Next slide, please. So to my earlier comment that we thought if we build it, will they come, we found out quickly that that wasn't necessarily the case. And so we had to put our innovation hats on and take on some community health workers that we could put into outreach locations. So we decided to have the community health workers employed by the providers. So we're really looking at a model in which the community health workers aren't representing the health plan, but instead are really representing the healthcare delivery sites in which they are employed. And we found this to be really important because they were really representing those clinics to the members, and thereby representing Hennepin Health, but at the same time kind of running out, I guess, a warm red carpet to those members that we were finding in other outreach locations back into those facilities, rather than seeing it as health plan facing. So essentially, we knew that we would have to build some relationships with community organizations and providers in which we felt that, or knew or suspected that many of our members where they were. And so we're looking, the locations that we were able to work out a relationship with and locate community health workers are listed here. So we have an adult correctional facility through Hennepin County where we found a lot of our members were spending time, and when they were in the correctional facility, they were no longer enrolled in the health plan, and so we really lost sight of them. So the care coordination teams in the clinics were saying, you know, I've got this case, I'm working really hard on it, and all of a sudden they just disappear and I'm not sure where they are. Fortunately, the correctional setting is also on the Epic Health record, and so we've been able to do some work to bridge that. But the community health worker is working, spending some of her time in the correctional facility, as well as these other locations. So a local homeless shelter, our emergency department at our hospital, where we're really focusing on diverting dental needs, and then also in our health plan lobby, which has an interesting phenomena of having a lot of members come and hang out in the lobby. And so we thought that might be a really great place to start. As far as how did we go about building the relationship, particularly with the shelter and the correctional facility, we really had to look at it as, you know, what's in it for them. And what we found is that a lot of these organizations are really looking to increase their capacity for health and wellness education, and that this is something that community health workers were able to provide, and it was a nice vehicle for them to interact with the members or the people who were, once they were discharged from the correctional facility, would probably be coming back on the Hennepin Health plan. Additionally, we found that there's a lot of motivation from these community partners to be able to attend to the whole person, and a lot of times they are, you know, focused on their small part of the individual, but we're realizing more and more that that we need to treat the whole person, and sometimes that means for them treating diabetes or heart disease when that's really not what they're experts in. And so we found that by sending someone who represents a clinic that there was a lot of motivation in partnering with us. Next slide, please. So the next program I'm going to talk about is what we call our ED Enreach program. So essentially this is a program that we started to address what we knew was high utilization that was avoidable and preventable of the emergency department. And we knew that if we were going to accrue or try to accrue quick cost savings to support our model, that we were going to have to address overutilization of the ED. And so essentially we embedded one social worker in the emergency department, and then our hospital also has what's called, we call it APS, it's the acute psychiatric ED. And that social worker is really the person that's kind of stepping outside of the chaos of the emergency department and the psychiatric ED and really seeking to find individuals who are enrolled in Hennepin Health and looking at why, kind of from a systems perspective of why are people showing up there for preventable things to help us really identify and target some of these problems and patterns. So we also have that social worker in the ED connect with a case manager that we have contracted through a local nonprofit. And that case manager is, we call him the ED Enreach case manager. And the goal is really to identify and target individuals in those settings where we think that case management services will help someone get back into a medical or behavioral health home. And so their goal is really reducing that utilization and finding preventative services to meet their needs. We had a lot of lessons learned from this pilot project. Initially, we thought, there's all of these people in the ED, so if we just put a worker there to meet with them who is engaging, that they would, not pass up the chance to work with her and get their needs met. But essentially, that wasn't the case, and it took us some time to really find the right worker. And we went through a couple of workers before we really found the right person to get this off the ground. So lessons learned is that that connecting with someone in the ED is not always the best opportunity. A lot of times we're looking at people who have altered mental status, are really just not in a place when they're admitted to the ED or when they're even waiting in the ED to talk to someone to engage with them. So one thing that we found is that by giving them cell phones while they were in the ED, that was one strategy that often took off pretty quickly. We weren't sure, but we programmed cell phones with the ED Enreach case manager, and then also our psychiatric and mental health crisis line, and the hospital contact, and asked them to follow up with the worker, and that's actually been quite successful. Additionally, we have had this ED Enreach case manager working outside of the ED with, in Minneapolis, we've got a great nonprofit organization called St. Stephen's that does street outreach, and so they've really been able to connect this case manager to a lot of the people that we're targeting simply by going where they're at, and sometimes that's homeless camps or places where the homeless are. Other lessons learned is that it takes a very specific staff person in order to kind of infiltrate the emergency room culture and the hospital and really connect with the individuals we're trying to serve. What we found is that we really needed someone who could fit into the hospital culture, so someone had some experience or understanding of a healthcare environment. One of my favorite stories is that when we first brought this pilot on board, the worker was not as familiar with healthcare settings, and we couldn't figure out why the emergency room wasn't connecting with her and wasn't giving her referrals. And I kind of found out on word on the street kind of way that her first day she came to work, she was wearing open-toed shoes, and this kind of made her a pariah in the ED with the staff. And it was one of those just simple things that really put up some major barriers. So that was a really interesting lesson. So essentially someone who has some of that cultural knowledge of working in an ED environment. We also found that you need to have someone who's quite assertive, and so not afraid to talk to people, get to know them, who can engage with clients very well, but also being able to engage and build relationships with the staff in the hospital. It was really important that they became integrated. And so some of the other things is having to be just very reliable. We found that when they can document in the medical record the same way and with the same standards of documentation that the hospital is using, is that really made their work quite apparent. And so when someone had made a referral to this program, when they would see that documentation of work being completed in the record, that really built their confidence that this work was happening and that it was worthwhile and it was helping their patients. And so that was a really important lesson learned. And then with all of that, so being able to fit in with the culture, getting to know and build relationships, we found that it's really effective to have this worker attending the in-hospital huddles, some of the clinics. So as we're asking them to bring people into the medical home or preventative care setting, that this worker is someone who is working with those staff, and so attending their meetings and their case consultations has been really important. All right, next slide. So thank you so much for having me today. I'll be here for question and answer at the end, and now I will turn it over to Lori.
Thanks very much. That was really interesting to hear, and I certainly connect with some of your lessons learned. There are some similarities definitely in the work we're doing and what we're finding out. Next slide. Let me, since Bill already introduced a little bit about my background, let me just get started with the program that I'm managing. Care Oregon's Health Resilience Program has been in existence about 4 years now. We started out at Care Oregon, and in the first year, after the first year that Care Oregon had said, we want to do this, we want to help our members and the providers out in the community, we applied for and were awarded, as Bill said, a CMI grant, which has supported our growth and learning and development over the past 3 years. So we just came off that June 30th of this year. Care Oregon is the largest Medicaid serving plan in Oregon, and you can see the numbers here, with a small amount of Medicare and dual members. The Health Resilience Program is a trauma-informed program, and I highlight that, and we'll talk more about that and why that is the focus of our work and our intervention. We have 30 direct service staff embedded in 23 clinics and 1 specialty clinic. We also started out with trying to embed someone in an emergency room, but didn't have the success that Julia's had. So we quickly moved to how can we support our members getting access to and building relationships with their primary care providers. We also have the struggle of working across 5 healthcare systems, which is 5 different, at least, EHRs, 5 different methods of approaches. We serve the most high-risk, complex patients in our program who have avoidable utilization. And the criteria is at the bottom of 1 or more non-OB hospital admissions with or without ED visits within 12 months, or 6 or more ED visits with or without a hospitalization within 12 months. Let me back up just a minute to further clarify. I'm sure many of you already know about trauma-informed care. But when I say that, it means that we're operating with the 4 values or fundamentals of trauma-informed care: transparency, offering choices, empowerment, and working in collaboration. And we do that both with our clients and our providers. So that is one of the main driver of our approach to working with the systems. We know that drivers of utilization for this population are usually multiple psychosocial issues and a huge amount of trauma history in the background of the people we work with. As the research demonstrated, with people who have trauma histories, they have a difficult time trusting others, especially authority figures. And we see that played out, as I'm sure you do, over and over again in trying to build a relationship with someone in a few minutes in a primary care setting. Our initial focus has been on establishing a trusting relationship with someone as quickly as possible. And we tend to work with people about 6 to 9 months. The 30 staff typically have a caseload around 20 to 25 clients. As I said earlier, we are embedded in primary care and in collaboration with them. So we have our health resilience specialist become a member of that team. We do most of our work outside the four walls of the clinic and walk with the patient in their world, really letting them know that we understand the struggles that they have. We can then bring that information back to the clinic, and it has really helped providers get a much deeper understanding of why their treatment plans aren't working and where the gaps are, because most of these members do not feel comfortable talking about deficit skills that they don't have. They don't understand English. They don't understand the treatment plan. They don't understand their medications. We work with adults, and we based our utilization criteria on Care Oregon's members. Every community has a different profile, and so we're specifically looking at our members. And what we found was that most of these members with high utilization that are not getting the care they need have at least 2 or more chronic medical conditions, as well as mental health and addiction issues, as Julie said. We saw almost immediately the need for a triage coordinator. When I talk about case finding, I'll talk more about that. We hired our staff for their engagement skills. They're good at building trust and engaging people. We found early on they were not so good at doing case finding. So we shifted gears and hired people who were very good at sifting through daily ED and inpatient reports that come to Care Oregon, and then finding referrals for our staff and getting it out to them. Next slide, please. The next slide shows you just a current snapshot of the number of people we've served since the beginning of the program. The CMI grant required us, as I said, to focus predominantly on the Medicaid population with some duals that we were helping. When the grant ended June 30th of this year, we were able to now ramp up our focus on our dual members, which were in just as much need and had just as many psychosocial barriers as our Medicaid members. Approximately, as you note here, 2/3 of those that we encounter and outreach to, and outreach meaning we see that you're having problems. We see that in our ED, and we know you've been going to the hospital. What can we do to help you? So it's a voluntary program. We invite people, and if they want our help, we join with them and start with them where they're at around addressing what they perceive are the health problems that they're having. Next slide, please. The strategies for finding members. We use multiple case finding strategies. We use utilization and the criteria that I have on the first slide. We also look at the medical, a deeper dive in talking with the doctor about what's going on medically with this person. So we look at the utilization from claims data and have an eye for, wow, why are they going? This doesn't make sense. They've been to the ED 3 times for falls. Something's going on there. They were admitted to the hospital for their diabetes out of control or their COPD out of control, and they keep going back in for that. Those are things that alert us, like detective work. Something's wrong here. We then have the health resilience specialist, in talking with the doctor, say, let me meet with the person. Let me ask them if they want some help. And then we're able to get into a deeper dive and hear about what the client needs and what they see the problem is with taking care of their health. When we go into a clinic, at each clinic we do a case finding just through the claims data utilization. And then we sit down with a list of names of clients and meet with the doctors in the clinic and talk about what they see as the problem. We work closely with the leadership of the clinic, and that is what really helps give our health resilience specialists the leverage they need and the boundaries around their work to target the highest utilizers and the population the clinic's having the most difficult time getting hold of. We also have the triage coordinators looking at the daily ED reports and giving our staff daily referrals when they see people utilizing or admitted to the hospital, utilizing the ED. That has been much more helpful to our staff, the more real-time referral source for them. And finally, once the clinic is understanding the high-risk population management approach, they start becoming the natural providers in the clinic. They're the ones who see what's happening with their patients. They're curious. And so maybe they aren't at that target criteria, but they see them ramping up. And that's very important for us to see and address before the patients become the high utilizers. We also have one of our supervisors and one of our triage coordinators visiting 2 shelters where we know homeless members are repeatedly discharged to and from the hospital. And then they cycle back into the hospital because they aren't getting the care they need. So once a week, the supervisor and triage coordinator go and meet at the clinic and actually help people know what health plan they have, what insurance, and if they're part of our Care Oregon membership, we do a warm handoff to the health resilience specialist at the clinic they're assigned to. So we make sure they don't get lost. We don't just give them a piece of paper. There's an outreach effort made to hold someone's hand per se and help them get into the clinic. We finally have the Pop Intel Registry, which is not so much a referral, although it does act as a referral mechanism for us. The registry was developed during the grant, and we saw it as critical to our track each case, each health resilience specialist tracking their clients by a list. It was also a place to document critical details about the life of the patients, whether it's the ever-changing cell phones, it's where they hang out when they're homeless. They're sort of the psychosocial notes and more so boxes because we really wanted to also track our interventions, what we were doing, how many times we were touching people, what we were doing with them, where we were doing it. So this is a holder of information that does not necessarily have the same place in all the different EHRs that our staff use at the different hospital clinic, the different systems of care that they're located in. We also can provide details about what triggers a client, how to approach a client, so that we can remember to share that if we lose track of the client or we need to let someone know. Remember, it's best if you approach Fred and ask him about his aunt who he's taking care of. That will really help cement a personal relationship for you. The other thing is given us metrics with which to provide stakeholders as well as inform our learning around what we're doing with our clients. That's how we know we have a 70% engagement rate. That's how we know we spend about 60% of our time out in the community versus in the clinic. So that has been an incredibly helpful tool for our program. Next slide, please. I've highlighted, as Julie also mentioned, hiring the right staff for this work. Our intervention is really about hiring trauma-informed staff, staff who understand how people behave with trauma histories, because what we see is that so many of this high-risk population are either getting fired from their primary care clinic, are not going or go once, or aren't telling their providers what's really going on with them. So we feel that being able to recognize those symptoms and help both the provider and the client have a safer visit and be supported in sharing information has been a critical tool for us in our engagement rate. This isn't about simply making contact with patients, but helping them establish and build a trust with the primary care provider and that team at their clinic. The other thing is we have time to build a relationship. We do not go in and do an intense intake. It's about doing a lot of listening at first. Our staff are primarily master's level in psychology or social work, and although they're trained as therapists, they do not do therapy with the patients. They use their therapeutic skills to empower and motivate people to change, to build trust, to be able to give feedback and support to the clients who have many, many skill deficits, as we all know. We don't see this as a quick fix. I don't even see it as a fix per se of anyone's longstanding history, but what we're doing is starting to do a reset for these clients and helping them develop a safe relationship with their primary care system or their specialist. We find that people, the staff we've hired, have a background in community mental health. They seem to be best equipped. That is my background, and I can appreciate all the work and the clients that we encounter. We're already trained in establishing trusting relationships. We not have knowledge of mental health and addictions treatment as well as symptomatology. We have cross-cultural training. We have a lot of experience in conversations about boundaries with compassion. We also have a lot of knowledge of local, ever-changing resources. We provide weekly supervision to the staff because we know, again, as Julie said, the high rate of burnout in this field is well known amongst those of us who have been in it and work in it. And so providing that weekly supervision and support and ideas so that our staff don't get too far down the path of trying to do too much, but more of a high-level systems connectivity and supporting and laying down some future foundation. Let me see. I just lost my screen a minute. Forgive me, but it's back. Again, over and over, the staff talk about how important it is to just listen at first. And we share that information with the providers in the clinics. We also get to see, by spending our time in the community with the clients, what their world actually looks like and how it works. And we can manage the misperceptions that come up in the primary care clinics around why people aren't showing up, why they aren't cooperating with the treatment, despite the best intentions of the providers. Can you, next slide, please? You're there. What is critical is for our staff is actually, as I said, walking alongside the clients. That builds the relationship so much. We go to appointments with clients if they want us to, but most do because they don't understand how the medical system works. We attend specialist appointments. Social service appointments. We help connect people into mental health and addictions treatment. We're teaching communication skills. We're explaining the system to them. We do a lot of translation time around what the provider is saying, what their medical team is saying, and breaking it down so that the clients really understand what it is that they're being told. We know that providers don't have time to spend with people, and so that's where we're an extension for them. And we also know that many providers are really frustrated with these clients and so don't end up listening to them or necessarily treating them that well because they're very frustrated and they're not sure what else they can provide, which is a really normal thing to have happen. So we found that we have become really a support to the providers in the clinic. When the client is better managing their health, what we notice is they gradually stop contacting us and they're contacting the clinic more often. We introduce them to peer specialists if they would like to continue some support, and in part we work with such a socially isolated group of people that what we see is they need help connecting to safe communities. Our peer specialists are very valuable in doing that and can follow through a little bit longer than we can. Next slide, please. Actually, the next two slides are some of the early results from 2013 of our program. And I just wanted to give you an idea that we've seen an impact on the clients of the work we're doing, although both show about a 35% reduction in either hospitalizations and ED visits. What we found in our close work with Jeffrey Brenner, who we modeled our team on 4 years ago, is that we can certainly guess there's going to be a 20% regression to the mean. So even if we're breaking even, so to speak, in terms of our costs and able to impact reduction of utilization and increase the attendance to primary care, we feel like we are doing so much to help providers in the community, and that's the feedback we also get, that our support and communication to the primary care clinic about their most difficult population have been incredibly valuable to them, and in fact a number of comments about providing hope to them about patients they've lost hope in. Next slide. This is so that's our ED results, which you can feel free to go and look at after my presentation. What I'd say in wrapping up is I think the key elements of our program, we have a foundation of a trauma-informed approach in building trust with people. It's client-centered. We start with where the client wants to start with their health goals. We work in collaboration with clinics. We have access to the EMR, and we have a registry that helps us document those psychosocial issues that are going on and that are critical to engaging this population. The registry is very essential in gathering metrics to show our stakeholders and to improve our learning about the population we're working with. And the other caveat is that we're not working on a billable hour. Working on a billable hour, as I think we can all agree, does not allow for us building a trusting relationship. So we have time to do this and go at the pace of the client instead of expecting the client to go at our pace. Next slide. These are a couple of videos I have on here that can tell you a little bit more about our program, and feel free to contact me or ask questions. So Bill, I'll pass this on to you. Thank you very much.
Thanks. Excuse me. Thanks, Lori, and thank you both, Lori and Julie, for such a great presentation and really awesome tips on how you've used outreach and other workforce, as well as leveraged your data and electronic health records and building strong community partnerships to find and engage your members. Amy, I'd like to know if we should move on to question and answer period, or if you'd like to do the poll that we had planned. I know that we're running a little bit short on time, so I'm wondering if we should jump right into questions.
Maybe do one of the two polls. Poll number one.
Okay. Poll number one. Great. So it's just kind of a question to get a little bit more information about you all as attendees here in the webinar, just to give our presenters a little bit of information about what you're thinking about, what you're doing right now on the ground. So this one looks a little bit back at the work you've been doing up to now. So which of the following have you found most successful to find and or engage your members? Pick all that apply. So community health workers, embedded in or outreach staff at community-based organizations, expanded access to electronic health records, use of a registry or some kind of priority tiering of hard-to-find members, free or low-cost cell phones to give to members, or none of the above. So pick all that apply, and I'll give you a couple of moments to select your answers. Okay, great. So we've got several hundred people on our webinar today, and we've got almost 65% using community health workers, so that's fantastic. Only about a quarter are using either a registry or priority tiering or free or low-cost cell phones, so it might be an opportunity there. So let's jump into questions right now. So I'll pass it over to Amy to lead that discussion with our presenters. Thanks again.
Great. Thank you, Bill. As a reminder, if you have questions, there's a few ways that you can submit them. You can utilize the Q&A feature on the web platform, or you can use our AT&T operator. Operator, at this time, could you remind our participants how to ask a question over the phone?
Thank you. Ladies and gentlemen, if you wish to ask a question over the phone, please press star then 0 at this time. Once again, to ask a question, press star then 0.
Great. And while we wait for that the questions to queue up, we have one question that's come in through the Q&A feature. For Julie, could you say more about the challenges or successes tied to giving members cell phones?
Yes, I can. I think there are lots of challenges with giving members cell phones. I'd say the biggest challenge is the fact that you probably aren't going to get the cell phone back. So initially we came up with a system, and we still try. We keep track of the cell phone. Each one is numbered, and we know who has it. And we had to determine, a period of time in which we would shut it off if we weren't in contact with the member. And then we did ask staff to do their best to try to get the phone back, but that hasn't been successful. So essentially, we're giving the member the cell phone, and we're acknowledging that they're probably going to use that cell phone, and they can use that cell phone for other calls, and I think that that's been somewhat of an incentive, and I think that is a benefit to engagement. And essentially, we had to kind of decide, if someone wasn't engaging at all, we would turn it off after a month. If they were engaging for a while, and that was critical to the engagement with the worker, we would continue to have the cell phone on until they ended services.
Great, thank you. Operator, are there any questions on the phone?
Yes, we do have a couple of questions. And once again, if you do have a question, press star then 0 at this time. Our first question comes from the line of Michelle Allen. Please go ahead.
Hi, I just had a question about the cell phones as well. These members, I work with the TANF population here in South Carolina, so they're getting the government cell phone. So this cell phone is in addition to the cell phone they're already having? Or they already have?
Yeah, we've got government cell phones as well that they lovingly call the Obama phones here. But some of those, a lot of the people who are engaging with this ED inReach, I mean, they may have a phone, it's not working, they've lost it. I mean, it really, we're seeing if they have a phone first. And if they don't have a phone, then we would give them the phone. And so sometimes it's an addition. But for the most part, we've assessed that they don't have a reliable way for us to connect with them. So
right, and
the
even
phone is lost or gone.
Yeah, I didn't mean to interrupt you, but even though when they do have the government cell phones, is it every time that they get a new phone or they add minutes that the phone number changes? Because it's like the phone number will change 3 or 4 different times. Or they'll call me and they'll say, I just got this new cell phone and the number's changed.
We find that a lot. So, that's been just a challenge with this population in general is that, it's like first of the month, people use all of their minutes right away. Their numbers change constantly. We get a lot of calls of, hey, I'm going to be waiting by this phone. If you call me right now, here's the number.
Yeah.
Of course, you get the message a day later and you can't find that person. So we did find that giving them the phone from the health plan has just been, it's been one of those things that we just know that there's going to be some, abuse of that. But I guess it's probably been just one of the most direct ways to do the outreach.
Yeah, I think that's an awesome idea too. Thank you so much.
Mm-hmm.
Thank you. And next we'll go to the line of Anita Holmes. Please go ahead.
Hi, this is Anita Holmes. My question was for Julie in regards to the 4 different models you were saying that you guys are using, the extreme, high, rising risk in general. Just wondering if you can talk a little bit more about each one.
Sure. So essentially, when you're using these hierarchical condition categories, you can cut and slice, and I'm not in the analytics group, so I can speak to this the best I can. But essentially, we looked at our analysts looked at all of the costs, and we were able to kind of slice the population into those tiers. So essentially, the extreme priority category, we determined that those are the classic kind of 5% that are costing us 40% of our costs. And so essentially that is in the 2 highest risk, we're noticing the smallest percentage with the most percentage of cost. And so we decided to put them into those 4 tiers. And, it's just a way, I think of it as a funnel. It's just a way of starting to do that prioritization. because some of the people who are in the extreme priority category are there because they've got unavoidable utilization or high costs. And so we're really telling our staff, we know that you're really overwhelmed. You need a way to kind of prioritize that, the people that are coming to you. We're really focusing on these extreme and high risk, but look at the patient, and their history and use your clinical judgment to prioritize the best that you can. So really trying to identify those really, avoidable utilization. And so essentially, we just had to accept the fact that we're not going to be able to provide care coordination as our population expands to everybody who needs it. And I don't know if this is true in a lot of other clinics, but we've found that you put some of these key staff in clinics and they are just sucked dry as far as how many people they could potentially be working with. And in putting, someone like a community health worker who's not necessarily trained, or would be expected to, I guess, set boundaries with the, providers who are asking these things of them. We found that the risk tiering categories actually was really helpful in putting those limits with the, higher ranking professionals they work with to be able to say, we're really trying to prioritize those two highest categories. And we really are hoping that the clinics, via the MAs or the receptionists at the front desk can take the time, and the other sort of normal primary care staff can take the time to work with some of those lower tier members or patients to provide the need that they have. I hope that helps.
Great.
Yes, it did. Thank you. And then also I was wondering, as far as the presentation, unfortunately I was not able to pull it up. Is there a website to go to or to get that later after this?
Yes, it's available on the WebEx. There's a green icon that has a little folder at the bottom of your screen. You can download the PDF, and it'll also be available on the Resources for IntegratedCare.com website within a few days.
Thank you.
And then we have another question here for both Lori and Julie. You both talked about the importance of hiring the right staff. Have you experienced any challenges finding or hiring staff who fit this role? Lori, do you want to start?
Oh, sure. Let's see. Yes. Let's see. It's hard to answer. We have I'm very proud of how we've been able to hire the right staff for the most part. We have only had out of 30-some people, one person that it didn't fit, we realized. They weren't able to remain neutral, and that's really critical here, not taking sides with against the patient, against the healthcare system. It's really like, let's just focus on what's happening right now for you. Everybody's doing the best they can. So one person, we couldn't do that, maintain that sort of Switzerland stance. And the other three, actually, when they got here, it wasn't really the kind of work they wanted to do. It wasn't what they thought it would be. This is definitely more in the case management realm and walking alongside people for a while and dealing with people who have addictions and mental health treatments as well. So that's where they realized that was a little out of their scope. They weren't comfortable with it. Other than that, we do behavioral interviewing, so we really can hear if people walk their talk. We ask if, for instance, tell us a time, what would you do with a patient who was non-compliant? And what I'm looking for one of those response to be is, well, I would sit down and ask them what they're having trouble with. And I don't like the word non-compliant. So listening for, let's see how we can equalize the relationship and and take some of the judgmental words out of the conversation. Does that help a little?
Great, yes, thank you.
Okay.
Julie, did you have anything you wanted to add on that question?
Sure, just real quick, I think it's really important. We found that that while you have to, hire for certain positions, if you're requiring a social worker or community health worker, for example, we really have found that licensure level, the field that someone is in is not actually the most important part. We found, similar to what Lori has said, you just really need to have someone who is passionate about this work, who understands, that a lot of this work is not about, this is not my job or this is below my scope. It's really about just doing what needs to be done, and being willing to do that with the patient. And I echo everything Lori said about a trauma-informed approach and non-judgmental and very patient-centered.
Let me add one other thing, Julie, you made me think of, which is early on we did hire non-master's level people, and at the same time some community mental health master's level people came over, not licensed but master's level. And so we were able to see the different skill sets, kind of like a microcosm next to each other, a little tiny experiment. And we still have employed those, one left, but we still have 4 people who don't have master's degrees, and they're great. So
yeah, I agree. I think some of our most talented and valued staff are community health workers, and in Minnesota their certification is just a 6-month program, and they're just the kind of people who just really are just so kind of patient-centered and mission-driven, and I just really think it's about the individual.
Thank you. We have time for a couple more questions, but I wanted to mention to the audience, we have our participant survey link up on the slides, and we'd really love it if you could take a few minutes to give us some feedback on this webinar to inform our future work. Thanks. Okay, and then I have another question for Julie. Can you say more about the Hennepin Health, how Hennepin Health developed its priority tiering algorithm and how you use it?
Yeah, so that slide talks about hierarchical condition categories, which is a tool that's available from CMS. We've got an analytics center for excellence working out of our safety net hospital, and they chose to use the HCC scores as a starting point because there is free software and analytics available around that algorithm, and those scores, and that's about what I know about that detail. But essentially, what we're really looking for, as I said in the presentation, is how do we even start that predictive rather than being reactive and looking at past utilization. And so really the HCC scores are based on diagnoses that the patient is given, as well as demographic characteristics, and it generates a score about risk for future costs. We did do an analysis of that, so looking back at people who had those scores, and they matched up pretty well. So we are fairly convinced that this is accurately predicting future cost. Thank you. At this time, I think we're at the end of our hour here, so we really appreciate, I wanted to thank our speakers again, Bill, Julie, and Lori, and thank you everyone for your participation. As we said earlier, please fill out our participant survey to inform our webinars in the future. And if you have any questions now or after the call, you can email us at ric@lewin.com. That's ric@lewin.com. And as a reminder, the slides, a recording, and a transcript will be available on our website after the call, resources@integratedcare.com. Have a great afternoon, and thank you so much for your participation.
Thank you. Ladies and gentlemen, that concludes the call for today. Thank you for your participation, and thank you for using AT&T Executive Teleconference Service. You may now disconnect.